Hi, this is Dr. Reynaldo O. Hoson, Director of R.O. Hoson Pep Talk. I have a patient empowerment program in which I'd like to empower the lay people or patients to take control in the management of their health. There are 3 courses in the Pep Talk. I completed the core course on October 9, 2021. From October 23, 2021 onwards, I have been tackling health disorder and health issue courses. This may take 3 years or longer. My pep talk today is entitled Breast Self-Examination, to do or not to do. This is part of the health issue course. The empowerment objective is for the lay people to have an understanding of the issues involved in breast self-examination. Breast self-examination, or BSE, is examining one's own breast. The other phrase that is being used interchangeably to mean the same thing is self-breast examination. What are the issues associated with BSE? The main issue is whether BSE should be used to screen for early detection of breast cancer. The other issues are being afraid to do BSE and accuracy worry of doing BSE by Filipino women. First issue, whether BSE should be used to screen for early detection of breast cancer. In the internet, one sees reports that BSE is not or no longer recommended as part of the breast cancer screening. Yet, one still sees a lot of websites continuing to advocate and educate women in doing BSE. So what should it be? To do or not to do BSE? Current arguments for not to do BSE, no longer recommending BSE. The U.S. Preventive Service Task Force recommends against clinician teaching women how to perform BSE. The Canadian Task Force on Preventive Health Care does not recommend breast self-examinations. Before the advent of mammography, BSE was included in the screening guidelines for breast cancer. With the advent of mammography, BSE, as well as clinical breast examination, or CBE, one that is done by a physician, is no longer recommended as part of the breast cancer screening. The reasons forwarded: BSE has not shown to be effective in detecting early breast cancer. BSE has not shown to be effective in improving survival or reduced death for women who had breast cancer. There are a lot of false positive outcomes that lead to unnecessary tests. There are a lot of false negative outcomes that delay detection of breast cancer. Arguments to do BSE, still do BSE. My personal stand is that BSE should still be a screening tool for breast cancer together with other screening tools like clinical breast examinations by a breast specialist who is an expert on palpation of the breast and mammography. Here are my reasons. BSE as a screening tool can detect breast cancer just as clinical breast examination, mammography, and other instrumental or laboratory diagnostic tests can. There may be differences in the diagnostic yield and diagnostic accuracy among the different screening methods, but BSE for sure can still detect breast cancer. That this is so is supported by the fact that before the advent of mammography, BSE was being recommended as a screening tool because it could detect breast cancer no matter what. Self-detection of something unusual in the breast by a lay person can initiate a medical consultation, which eventually can lead to a diagnosis of breast cancer if that something unusual turns out to be cancer. BSE can detect breast cancer in the early stage as long as the patients will report their findings to the breast specialist early enough. By the way, breast specialists that I am referring to are the general surgeons or breast surgeons who do a lot of palpation of the breast in the clinics and who have gained expertise in the process, especially when they validate their clinical breast examination findings with the operative findings in case the patients undergo operations. The breast surgeons are the expert palpators of the breast and have the highest accuracy in detecting breast cancer by physical examination, more than the gynecologists, medical oncologists, and radiation oncologists. BSE can and has detected breast cancers in the localized stage and stage 1, meaning less than 2-centimeter tumor. Its limitation is that it will not be able to detect through palpation a breast cancer tumor that is less than 5 millimeters. Bigger than this, usually 1 centimeter in size, it will be able to detect through palpation. Stage 1 is still considered as early stage cancer. It is true that mammography can detect breast cancer tumor at a microscopic level up to a size smaller than 5 millimeters. That is the advantage of mammography over BSE. However, this advantage of mammography does not and should not negate the ability of BSE to detect early breast cancer as early as stage 1. Those patients with early breast cancers detected with BSE who were treated early have better survival rates than those patients who presented with advanced disease. Thus, BSE is able to reduce breast cancer death if it detected cancers in the early stage, localized or stage 1, and the patients subject themselves to early treatment. It is given that no diagnostic procedures and tests are 100% accurate at all times. BSE has its own share of or percentage of non-diagnostic yield and inaccuracy. The other diagnostic procedures and tests, such as clinical breast examination and mammography, likewise have their own share or percentage of non-diagnostic yield and inaccuracy in terms of false positive and false negative findings. BSE's false positive findings may lead to unnecessary tests. This negative situation or limitation of false positive findings is also present in CBE and mammography. A BSE false positive findings can be corrected right away without undue harm to the patient by the CBE, by a breast specialist. The BSE's false negative findings may yield to delay in detection of early breast cancer. Again, this negative situation or limitation is also present in the clinical breast examination and mammography. A BSE false negative findings can be corrected soon or early enough if BSE is being practiced on a regularly close interval basis, such as monthly. A false negative finding may be changed to a true positive findings in subsequent BSEs. The advantage of BSE, if done regularly, usually at the recommended monthly interval, is that it can detect a false negative result earlier because of repeated close interval examinations compared to a clinical breast examination and mammography, whose repeated examinations are usually done at longer interval, usually ranging from 6 months to 1 year. The reason for warded against BSE as well as CBE to favor mammography is that BSE and CBE have a lot of inaccurate findings. The truth is, mammography also has a lot of inaccurate findings. There may be studies that show mammography has a higher diagnostic accuracy rates than BSE and CBE. The report should be taken with caution. Mammography are being done by radiologists who are trained in reading mammography plates. They are specialists in a sense. So one expects higher diagnostic accuracy rates than lay people doing BSE and general physicians doing CBE. If the lay people are well trained in BSE, and if the CBE are done by breast palpatal specialists, the figures in the diagnostic accuracy rates may not differ much among the three screening methods. Another reason to support my personal stand, in those medical societies recommending against the use of BSE in favor of mammography, there's always a statement of however, quote and unquote, like so. However, it is very important for women to be aware of how their breasts normally look and feel, and to report any changes to a healthcare provider right away. This is especially important if a woman notices a breast change at some point in between her regular mammograms. Aren't these statements referring to BSE? Isn't this a recognition and appreciation of the ever-present value and usefulness of BSE? So why do we have to make guideline statement excluding BSE? From my perception on the new changes in the screening guidelines of the US PSTF and the Canadian Task Force on Preventive Health Care, I think this came about because mammogram has been reported to do better than BSE and CBE in terms of capability of earlier detection of breast cancer and more reduction of breast cancer death as a result of earlier detection. On this basis, CBE and BSE were junked totally as screening methods. I don't think this should be the case. For me, BSE and CBE can still be used as screening methods for detection and also early detection, for that matter, of breast cancers, together with mammography and other screening methods that may be found useful now and in the future. The screening methods do not have to be one only or exclusive, such as just mammography. They can be done in combination and in sequence. First, remember, history-wise, before the advent of mammography, BSE was included in the screening guidelines for breast cancer. It had served the community or population well in detecting breast cancer early, and as a consequence of this early detection, it has reduced breast cancer death. Second, despite the advent of mammography, up to now, majority of breast cancer patients have detected their breast cancers not through mammography and CBE, but through BSE, most of the time, accidentally, and at times because of a developed health habit of doing regular BSE. Third, there is no national program that requires and/or subsidizes screening mammography for all citizens. For those who cannot afford out-of-pocket payment of mammography and do not subscribe to mammography, just as not everybody subscribes to COVID-19 vaccination, an alternative has to be offered. BSE is still the most practical method or alternative as it's cost nothing to every citizen. The things left to do are that it should be inculcated and taught well to the population. For me, I repeat my position. The screening methods do not have to be one only or exclusive, such as just mammography. They can be done in combination and in sequence. It should start with BSE, then CBE by a breast specialist, and then mammography for the high-risk population, particularly those with a family history of breast cancer. The BSE carries no expense on the part of the citizen or patient. It is simple and can be done repeatedly, anytime and anywhere. It should be taught and practiced well by the citizens or patients. It should be taught by the breast specialist. The second issue, afraid of doing BSE by Filipino women. In my medical practice during the past 40 years, I have encountered a significant number of Filipino adult women who have expressed their fear of doing BSE. Mind you, this is different from declaring that they don't know how to do BSE as a reason for not doing BSE or wanting to do BSE. This will be the third issue that I will discuss later on. One specific reason forward then is that they are afraid to find something fearsome, particularly breast cancer. I don't know the technical term for this phobia, maybe xenophobia or fear of the unknown. This situation is present in real life, not only for breast cancers, but also for other diseases. They are afraid to do self-examination of their own bodies because of fear of finding something fearsome. Such unfounded fear may lead to late detection of breast cancer regardless of what screening methods are being recommended, CBE and mammography included. People with this kind of fear or attitude will not subject themselves to any kind of screening methods. So what is the solution here? Education, persuasion, and psychotherapy if indicated. Another reason forwarded for being afraid to do BSE by the Filipino women is the belief that touching or palpating the breast may cause breast cancer. This is a myth that has arisen from the belief that trauma or a bump is a cause of breast cancer. A bump on the breast does not cause breast cancer. The background story behind the myth is that the painless, unnoticeable cancer has been there in the breast even before the bump. One day when the bump occurs on the breast that contains the cancer, the person reflexly touches her breast, and lo and behold, the cancer is discovered. This is the origin of this myth, believing that the bump caused the breast cancer. It is not true. A bump on the breast or touching or palpating the breast can cause breast cancer. So what is the solution here? Education and persuasion. The third issue, they don't want to do BSE because they don't know how to do it. Very superficial reason, but this is a common reason presented. There may be a deeper cause though, probably afraid to find something fearsome and believing that doing palpation can cause breast cancer. So what is the solution here? Resolve the deeper causes first, then convince the lay people of the usefulness of BSE. Once they are convinced, teach them properly. Before going to how to do BSE, some essential pointers to remember. All women should start developing a habit of doing BSE as early as age 20 as part of their preparedness program in detecting breast cancer in case one unfortunately develops in their bodies. Breast cancer is still rare in this age group. It starts coming out at age 30 to 40. So at age 20, there is a lead time of 10 years in developing BSE as a health habit in detecting early breast cancer. BSE consists of inspection, meaning looking at anything unusual on the externals of the breast, and palpation, meaning feeling the breast for an abnormal mass. In palpation, one has to differentiate lumpy breast tissue from a real mass, which is medically called dominant mass, or a more or less round or oval lump, which with a feel that is different from the surrounding normal breast tissue. If there is a palpated dominant mass, automatically it is considered as a red flag. So for further investigation, as it signifies an abnormality. Showing the lumpy breast, which is the presentation of a patient, of a person with fibrocystic changes or normal breast. showing the dominant mass, okay, which one that's somehow round or oval, which stands out, different from the surrounding tissues. If this is present, this is considered as a red flag. For menstruating women, it is usually advisable to do BSE a few days after the last day of the mens to avoid hormonal swelling of the breast tissue during mens being mistaken for a dominant mass. This is aside from avoiding the discomfort induced by palpating a breast that is usually sensitive during the time of menstruation. For non-menstruating women, it is usually advisable to choose either the first or last day of the month for doing a monthly BSE for ease of memory. The first goal of BSE is to look and feel for anything unusual on the breast. Once something is unusual is found, either it is closely monitored for persistence or it is brought to the attention of a breast specialist already. The self-monitoring of doubtful unusual findings can be done with repeated BSE on the same day, subsequent days, or next month. The second goal of BSE is to try to interpret the unusual findings as much as possible. If unable to, and a red flag is present, consult a breast specialist right away. There are many techniques as there are authors. Choose one that is simple and practical to do as long as the endpoints or goals are reached, especially the first target or the first goal. I have a video in the YouTube with this URL. I will not be presenting it here now. Okay. But this is how to do breast self-examination. My suggestions. Okay. So first is visual inspection or looking. Expose the upper body in a standing position. Face a mirror to view the entire chest and breast. With both arms down and then raise over the head, look for anything unusual on the breast. Look for changes in the contour of the breast and armpits, such as bulges, skin dimpling, and flattening. Look for unusual changes on the skin of the breast, such as redness and lesions. Palpation or manual palpation or feeling. In a standing position with one arm raised over the head, using the flats of 2 to 3 fingers, the second to the fourth fingers of the other hand, gently but firmly palpate the entire breast on the side where the arm is raised. Feel for anything unusual in the breast and feel for a possible presence of a dominant mass. The dominant mass is an unusual density distinct from the surrounding breast tissues with a felt margin or border which connotes a three-dimensional lump. Cover the entire area of the breast while palpating by going from one quadrant at a time until all the 4 quadrants are palpated. Before palpating the armpit, gently squeeze the nipple for possible presence of discharge. If there is, note the color, whether it's red or not. When palpating the armpit, put the arm down and have a lax or slack skin fold. Place the palpating fingers initially at the uppermost portion of the armpit, then gently press but firmly press against the chest wall in the armpit and slowly glide the fingers downwards to feel for anything unusual and to feel for a possible presence of a dominant mass, usually a lymph node. Repeat the same procedure in examining for the other breast, the nipple, and then the armpit. Interpretations of findings of BSE, which is also important to know. Okay. Lumpy breasts, no dominant mass, fibrocystic changes, which is normal. Okay, if there's a dominant mass, it is a red flag. So no dominant mass found on physical examination, on palpation, in patients complaining of breast mass, and in patients coming for breast check. So the diagnosis is normal or fibrocystic changes. Breast pain with no dominant breast mass, fibrocystic changes. Non-sanguinous or not red nipple discharge with no dominant breast mass, fibrocystic changes. Sanguinous or red nipple discharge with no dominant breast mass, intraductal papilloma. Focal erythema or redness or tenderness with no dominant breast mass, mastitis. Focal erythema or redness with a tender, fluctuant, dominant breast mass, breast abscess. Cystic mass with no signs of malignancy, macrocyst. Suspect cancer in the following: presence of a dominant breast mass with telltales or giveaway signs of malignancy, which include signs of local invasion of the breast mass on the adjacent tissues and signs of spread. And also suspect malignancy if the the nipple discharge is sanguinous or red, and then there is a concomitant or accompanying dominant breast mass. Cancer suspect in the presence of signs of local invasion of the breast mass on adjacent tissues, which usually can present with fixation to the adjacent tissues, such as the overlying skin, and inclusive of the nipple and areola, and underlying tissues such as the chest muscles and ribs. Skin changes over the mass that are suggestive and indicative of local invasion, such as ulcerations and fungation. Another sign of spread, presence of palpable ipsilateral armpit lymph node and supraclav, so above the on the neck, okay, supraclavicular lymph node. So summary takeaway: do not listen and be discouraged by the negative recommendations on BSE. Do not be afraid to do BSE, as it will not cause breast cancer. Do not be afraid to do BSE because of fear of finding a breast cancer. If there is breast cancer with BSE, it will be detected early enough. Do not simply say you don't know how to do BSE to justify your reasons for not doing BSE. You have to learn how to do BSE because of its usefulness. You can easily learn it as it is simple. Develop BSE as a health habit. Make it as your first and mainstay screening and detecting armamentarium for breast cancer. You can complement BSE with CBE, mammography, and other screening methods as needed and indicated. Do not rely solely on mammography and even CBE, as they may give a false negative findings at the time of examination. And if you do monthly BSE, you may be able to discover a dominant mass that may appear before the next mammography. This way, you are able to discover a dominant mass early. Doing regular BSE is an investment for your breast health. Nobody knows when a breast cancer will strike. Do monthly BSE so that once breast cancer strikes, you can detect it early enough. With early detection, recognition, and early treatment, your chances of cure will be high. If you don't do BSE, and if a breast cancer appears in and is already in the advanced stage, you will be blamed for the situation. You did not love yourself and your body enough. BSE as a health habit is simple and without cost. It can be repeated anytime without added cost. It can be done anytime and anywhere. It can detect breast cancer and other breast diseases. It can detect early breast cancer as long as it is done regularly and properly and as long as it is reported to a breast specialist early enough. Consult a breast specialist right away once a dominant mass is detected during BSE. Takeaway in relation to patient empowerment: be always in touch with reliable medical information on fundamentals and generalities in the medical management of breast disorders, especially cancer. Knowledge is power. It gives power. Use the 4 Ks of patient empowerment: kaalaman, kakayanan, karapatan, and kapangyarihan to gain greater control over decisions in the management of your breast health. So with that, I end my pep talk: breast self-examination, to do or not to do. I hope I have empowered you to have a better understanding of the issues involved in breast self-examination. With that, I'd like to say thank you and good day. Mabuhay kayong lahat.